What you do is you put your thumbs on either side of the patella. And I asked Jordan, okay, can you contract your quad? Okay. What you want to see is that the patella stays within the track of my thumbs. Okay. What would happen is if she derails, which means she has an insufficient VMO, would be this patella would whoop, come out and either push against my thumb or actually override it. Okay? She actually does pretty well. So, and tighten. There we go.
Nice.
And relax. That was better. And relax. What you will see on somebody who has a big issue going on with their VMO in the firing pattern of that, it will just, track laterally hard. Okay? And you either, like I said, feel it against your thumb or it just pushes your thumb right out of the way. If I ask this patient, just relax and I'm going to move your patella, and I start gliding it laterally, what she will do is she'll either go like that, and that's apprehension. That makes her apprehensive about dislocating it again. So she either has that funny face or tells you to stop. So what you're going to do is you attempt to try to push and tilt the patella laterally, okay? And you get the lateral part of the patella come up like this. Okay? And again, what you don't want, the test is positive if the patella cannot be lifted horizontally or subluxes out laterally. Okay? You want to be able to do that. Okay? Sometimes you even do that, and I check the undersurface of it, see what's going on. What you're going to do, you can do this in sideline, you can do it in supine. All right? But you're going to bring them up. You are going to palpate the distal part of the ITB and put your thumb there. Okay? And compress it. Okay? And then what I do is I flex and extend the knee. Does that hurt? A little bit. Okay? If she has pain with this, okay, and this says usually at about 30 degrees, which is probably about right, okay, that is positive, okay, for ITB friction and or tightness distally. A great way to treat this sometimes is to put the patient into the over position, okay, and as she's here, I can start with her out extended, okay, and just relax, okay, and I can glide her patella medially. Just by doing that, I'm getting a stretch in through, okay, her retinaculum and the ITB as it's threading its fibers, okay. I can drop her even more with the lateral glide here, okay, you feel that? And then I can get in here and deep friction.
I don't want him rotated outward. I basically would like it to start off my assessment with his kneecap pointing straight up. Now, most patients, if they're tilted at all, it's going to be tilted laterally. Now, if they have a lateral tilt, again, it's either due to this tightness that they have on the lateral side, so that retinaculum is tight, or if you look at that slide, I'm not sure it shows a great picture, but in some patients, it's just the shape of the trochlea. It's just that patient, and it's just who they are. So you're going to have some people that you guys look at today who, it could be just the shape of their femur that makes them look laterally tilted, or they are laterally tilted. If they've got a laterally tilted patella, but the lateral tilt test is negative, then it's probably a bony thing, all right? But if they have a laterally tilted patella and they have a positive tilt test, then it's probably a soft tissue thing. So we do that lateral tilt test when we have somebody who appears to be laterally tilted, okay? I'm getting my thumbs on the outside edges of the patella. So outside edge, inside edge of the patella, and I am looking to see, does the lateral aspect of the patella seem any lower to the table than the medial aspect of the patella? Now, Jared, you're a smart guy. What do you see here?
Yeah.
Yes.
Lateral.
So Jared has a huge laterally tilted patella. I can see that. He can see that. You guys might be able to see that. So Jared has a laterally tilted patella. This side of the patella is down lower to the table as compared to this side of the patella. Now again, that could be just Jared. He didn't have a positive lateral tilt test, I think, right? So, he's slightly positive, actually. He is a little bit positive because what happens is when I try to tilt him, he starts to sublux laterally. So he actually does have a slight positive lateral tilt test. So he could benefit maybe from some soft tissue work or some taping or something like that. But I would just say, make yourselves kind of a stick here, stick it through the femur, and then go ahead and get an assessment of whether there's a shorter distance on one side versus the other. So Jared is actually laterally glided. The distance is shorter on the lateral side of his kneecap than it is on the medial. So he's laterally glided. This is an example of an externally rotated patella. Okay? So what I'm going to do, and I do this, I eyeball this. Okay? You can take a pen if you want. You can take 2 pens, and you can say, I'll take this one, and I will take this one, and I will bisect the 2. Ideally, these should be in line when I palpate the inferior pole of patella. On Jared, what do you guys see? Are they in line or are they not in line? They are not in line. Ideally, he would be more like this. So he is externally rotated. I've never seen someone who's medially rotated. I've never seen somebody who is medially glided. People are usually, everything is just usually too loud. But I look to see, is that inferior pole look significantly lower than the superior pole? You know, if he's asymptomatic, I don't really care. If he is symptomatic and he's getting some fat pad irritation or a hypertrophy of the fat pad, then I'm going to pay a little bit more attention to that. So this is, I think, probably the most subjective because everybody is tilted a little bit to begin with, so it's kind of like hard to know what's normal and what's not normal. Jared is a little bit inferiorly tilted, but it's not something I would necessarily do anything about. If I am taping for just a glide component or just a tilt component, then I only need 1 strip of this anchor tape. But if I'm going to tape for a rotation component, then I have to use 2 strips of this tape. So what I'm going to do is I'm going to put 2 strips of tape just to show you guys. I'm going to have 2 strips of tape on his knee. So each piece of tape goes from condyle to condyle. I do not want to leave any gaps so you can overlap it a little bit. You never, ever, ever want to put the brown tape on their skin because then you will take their skin off if you leave it on for any length of period of time. Medial glide is a long piece. And I'm going, essentially, again, I'm going basically coast to coast. So what I'm going to do is I start on that very lateral aspect here. So I want to get a lot of surface contact here with the tape. Anchor it well. Thank you. And then what I'm going to do is I'm going to take the tape and I'm going to take my thumb at the same time and push his kneecap over. And as I do that, I'm kind of like pinching the skin sort of together. I'm going to see some creases here. Okay, so I'm just kind of pulling that kneecap, and I'm taking this tape and I'm pulling it pretty hard. All right. If you are not seeing creases when you do this, you haven't taped aggressively enough. So if the glide was his only issue, then I would only do a glide piece, and that would be it. All right. So you tape for what you're seeing. Okay. Let's say I want to correct the tilt component. The tilt component is very much like the glide component, except I start at the mid-patella. So I start at the middle of the patella. This is a shorter piece, okay? And what I'm going to do here, I want to go about from the middle of the patella, okay? So I start here, right on the middle of the patella. And then what I do is I kind of do like a lateral tilt test in a way. I'm going to push the medial part of the kneecap down. So I'm not pushing it over. Now I'm trying to compress the medial part of the patella, and I'm pulling it down at the same time. And ideally, you're going to start to see that lateral facet kind of lift up a little bit. And really, the only one that you're not starting at midline for is the glide piece. The other 2, we are starting at midline. What we're going to do now is we're going to correct the rotation component. I can start at the top of the patella here and pull down, okay? Or I could start at the bottom of the patella here and pull up. I'm going to start at the mid-patella, and I'm going to take my fingers, and I'm going to rotate his kneecap. So I'm just going to take it and rotate it, whoopsie, and I'm going to pull my tape down at the same time. So I'm going to try to pull it down like this, and then anchor it down.